All right, it's noon, so we're going to go ahead and get started. Thank you so much to everyone for joining us for today's Spring into Health event. My name is Haven Spanier, and I'm the Senior Director of Programming at the U of SC Alumni Association. And it's my pleasure to get to introduce our host to you all today. But before we get started, I do want to encourage your questions throughout today's event. If you have any, you can type those into the chat or into the Q&A, whichever one's easier for you. We will do our best to get to as many of those as possible today. If you aren't super familiar with Zoom, there should be a panel across the bottom of your screen. There should be a chat button and a Q&A button on that panel. So please feel free to type in your questions as we go today, and we'll get to the presentation. But without further ado, I'd love to introduce you all today's host. Dr. Davis received his medical degree from the Medical University of South Carolina. He completed his residency in internal medicine at Los Angeles County Hospital and a fellowship in geriatric medicine at UCSF Medical Center in Mount Zion. Dr. Davis is certified by the American Board of Internal Medicine. So thank you so much, Dr. Davis, for joining us today. I know we're all really looking forward to hearing your presentation.
Great. Well, thanks for having me. The topic today is kind of near and dear to my heart. I spent most of my career out at UCLA doing primary care geriatric medicines. And so all of my patients were over 65. And when I moved back to South Carolina about 8 years ago, I joined our geriatrics group here at what is now Prisma Health in Greenville, and have been working in a memory care program. So we have a special program for evaluation and care of people who might have Alzheimer's disease or other disorders that affect memory. So today's talk, was an opportunity for me to kind of think about some of the more recent developments in the area around Alzheimer's disease, and kind of go over them and maybe bring some of you up to date, or try to answer questions where that you might have. Alzheimer's disease is a large and growing problem for the health system. There's more economic, more money is spent on caring for people with Alzheimer's disease than for people who have cancer or for people with heart disease. So it's a important problem, and any progress that can be made in the area of Alzheimer's disease will be a benefit to all of us. These are some of the topic areas I would like to touch on today, and we'll kind of go through them. I tried to pick things that might, be of interest, or where there might be some new information. So, for example, when we think about diagnostic tests or treatments, there have been reports just within the last year that update what we know about treating in Alzheimer's disease. So we're going to go through these list of topics today. I want to start with these definitions. I'll talk a little bit really about baseline. What does the brain do for us? And the brain is sort of the controlling organ for the whole rest of the body. But when we think about diseases like Alzheimer's disease or dementia, we are really thinking about diseases that affect the thinking brain. And when we think about the thinking brain, we break it down into different domains of brain function. So memory is certainly a critical function. We need memory to get us through our days, to tell us what we've already done and what we have planned to do later in the day. And we need memory to tell us what happened yesterday. Long-term memory is kind of the collection that we have of long-term memory kind of makes us who we are. It's sort of the sum of our life experiences and the effect that those experiences have had on the way that we think. The other functions that we think about in the brain are the ability to plan and execute activities. So we think of executive function as being very important. Executive function hinges on humans' ability, in a sense, to foresee the future. There are very few animals that can picture what a house might look like and then be able to go through all the steps it takes to build a house. So executive function is critical to human function. Communication, again, highly developed in human beings. This ability to speak and convey information from one brain to another through these complex signals is highly developed, and a large part of our brain is taken up with communication and language. Orientation, staying oriented in place and time, relies in part on memory, but also on how we use visual cues and how we envision space around us. The ability just to pay attention, to concentrate, and to attend to an activity is a higher cortical function. And of course, as we look through this list of brain functions, any of these, and often all of them, are impaired in persons who have Alzheimer's disease or who might have other kinds of dementia. Just to kind of round it out, it probably turns out that if we look at all of brain function, if we were to measure the metabolism of the brain and the activity of the brain, more of our brain is spent just in maintaining body activity really than in thinking. But the unthinking brain, emotions, drives, the eyes and ears connect directly into the brain. That's how we perceive the environment. And so those are neurologic systems. But vision and hearing, at the level of our understanding of what we're seeing and hearing, those take place within the brain. Other types of perception, sensation, touch, motor function, all of these are activities that are directed connectly to the brain and to brain function. And so that interaction between cognition and these bodily functions is well understood. And so anyone who's been afraid because of something they've thought of or seen will have a reaction that leads to sweating or a rapid heart rate because of those connections through the nervous system. I think, when we start out on a discussion about these conditions and diseases that affect the brain, it's important to have some understanding of what normal changes are. What can we expect to happen as we age? The brain ages just like other organs in the body. And so there are certain changes that we think of as normal aging. Mild memory loss is common. Word finding difficulties, sometimes remembering specific names of things. We sometimes lose that ability. Retrieval, slowing of retrieval. I got up out of my chair to go get something. I got there, I wasn't quite sure what it was. I turned around and headed back to my chair, and then that memory, what it was that I was going to do, came back to mind. Speed and efficiency of thought decreases as we get older. Your ability to get through information material quickly slows down to a degree. I think it's important when we talk about normal aging that these age-related changes in brain function do not interfere with everyday activities. If there are changes in function that interfere with a person's ability to maintain themselves, then that's sort of the definition of a disease state, and we begin to think about those as problems. The changes do not cause confusion or disorientation. I can tell you, as I've gotten older, I use this standard. When people are telling me about their problems with memory and thinking, I always say, well, if it's worse than what I have, then that might not be normal aging. But if it's what I have or not as bad, then I consider that normal aging. It's unfortunate that we're using this video, so I can't listen to all of you chuckle over my joke. But that's the standard I use in my office. if it's worse than me, then it might be a problem. So we'll see. These are things that you can still do as you get older. You learn new things, create new memories. I had a retired physics professor who was a patient of mine out at UCLA who would come to see me. And he walked into my office one day and he said, "Dr. Davis, let me show you something. I've taken up the clarinet." And sure enough, he was in his 80s. He pulls a clarinet out and starts to play a tune on the clarinet. And he also gave lectures on quantum physics to people in the retirement home where he lived. So he had a very active brain and was excited about learning new things. So I think aging does not interfere with your ability to learn new things or have new memories. You can work on vocabulary and language skills as you get older. There's nothing to prevent us on the basis of aging from doing these things. As we kind of move away from normal aging, I'm going to talk about a couple of syndromes that the way we sort out problems that relate to changes in brain function. We use this term mild cognitive impairment, which refers to a condition in which a person has some complaints of memory loss or some complaints of changes in brain function. When we do a cognitive test, do a brain function test, we in fact see that there is impairment in memory. And yet these changes that are occurring do not interfere with daily function. So we don't call them having dementia. This is kind of an intermediate term, this term mild cognitive impairment. What a person with mild cognitive impairment might be in the very early stages of dementia, or they may have had a brain injury from the past, or they may have had some other effect on the brain, and they may not get worse over time. But on average, if a person is thought to have mild cognitive impairment, the risk that they will go on and develop a true dementia is increased. A common question in my office is, what's the difference between dementia and Alzheimer's disease? Dementia is a term that describes a syndrome. It describes a collection of symptoms. And Alzheimer's disease is the most common cause of dementia. But these are the Diagnostic and Statistical Manual, that DSM is sort of is a book that lists the definitions of different psychiatric and cognitive disorders. And it includes criteria so that all doctors and all researchers use the same criteria when we're describing these disorders. So dementia is an acquired disorder. That means that it's a condition that develops due to changes that are occurring. So this a person who has a learning disability wouldn't be defined as having dementia necessarily. Now, a person with a learning disability could also develop dementia, and that can make diagnosis complicated. To meet the criteria for dementia, a person should have impairment in 2 or more domains of cognitive function. And there I listed again those different domains that we talked about of brain function that we talked about earlier. And to meet criteria for dementia, these impairments must interfere with daily activities. It means you can't keep up with your medication and take it accurately, or you get lost when you're driving, or you're not able to pay your bills on time. So when you have these changes in brain function, it impairs function. That's when we apply that term dementia. These are just an overview of kind of the various causes of dementia. I've kind of put them in different categories. Alzheimer's is a degenerative disease, and then some of these others, Lewy body disease, frontotemporal disease, Parkinson's disease, all of these are conditions that have different clinical pictures. These patients have different symptoms and look different, and over time progress to having the characteristics that we would use to describe dementia. Dementia is a very late development in classic Parkinson's disease, but it can occur. Vascular disease so Alzheimer's disease is the most common cause of dementia and accounts for between 60 and 80% of the cases of dementia. Vascular disease is the second most common cause. So vascular disease in straightforward cases are people who've had strokes or TIAs. They may lose some part of brain function and then develop dementia. But other conditions that predispose to vascular disease also predispose to the development of dementia. So people who have high blood pressure, diabetes, people who've had multiple bypasses, who have significant heart disease, all of everyone who's had these is at increased risk of developing circulatory problems in the brain that can lead to dementia. Since both these conditions are common, a lot of people have an overlap. So we use the term mixed dementia because many people have elements of both vascular disease and degenerative disease. Infections like encephalitis and AIDS can certainly produce dementia. There's a question right now. I've had a number of patients that I've seen just in the last 6 months who came in, and the family, or the patient, I was doing fine. I could do things. I was fine. And then I got COVID and I was sick and I was in the hospital. And now since I've come out, my brain isn't the same. I've got, and this is a phenomenon that's been recognized. So there are some neurologic implications from COVID. It's not really well understood yet. I don't know what the pathology of it is, but I'm definitely on the lookout for it. And I've definitely had a couple of patients who really the symptoms of cognition developed in concert with an episode of COVID. So there are models for this. People who've had the flu and other types of infections that get into the central nervous system can certainly develop chronic changes in brain function or dementia. And then head trauma is another cause that can lead to dementia. So this chronic traumatic encephalopathy that professional football players get has been identified here in the last number of years as a cause of dementia. So these are just some groupings. There are probably 50 or 60 different causes of dementia. Chronic alcohol abuse, other types of substance abuse can lead to chronic changes in brain function as well. Alzheimer's disease, as I'd mentioned earlier, is the most common cause of dementia, and the exact pathology in Alzheimer's disease is, exactly what is going on is not completely understood. We do know that amyloid accumulates. There's increased production of amyloid, which is an abnormal protein, and then the clearance is decreased in people who have Alzheimer's disease. And amyloid congregates in what are called amyloid plaques, and wherever these plaques are, there are degeneration of the nerve cells that are involved around them. Another abnormality is these collections of tau filament, and tau just refers to a type of protein that collects in these tangles. So plaques and tangles are the hallmark features of Alzheimer's disease, and exactly how those tau filaments form and all, I don't have a real detailed knowledge of that, but there's a great deal of research in this. So 60 to 80% of older people who have dementia have Alzheimer's as a primary finding. Interestingly, there's an age-related collection of amyloid in the brain as well. So even in persons over the age of 85, even in some who've never been diagnosed with dementia, about a third of them have some of these amyloid changes in the brain. So I think there is an age-related accumulation of amyloid, but for most people, it doesn't get to a point that produces what we would call dementia. And then cerebrovascular disease, again, is very, very common. These conditions like hypertension and diabetes are very common, and they are common in people who in postmortem examination have both vascular changes and Alzheimer's disease changes together. So I want us to think of Alzheimer's disease as a neurodegenerative disease that leads to certain pathologic changes, but vascular disease also it goes with it and may be related to the development of these Alzheimer's changes. The overall incidence of dementia in this country has been going down, and most of that is thought to be done due to early screening for vascular disease, lowering of cholesterol, screening for high blood pressure. All of these risk factors have been attacked very aggressively in order to prevent heart disease, and certainly have led to some prevention of dementia in later life as well. The prevalence of dementia, unfortunately, is going up because our population is aging, and the more old people around, the more of us are at risk. This is just a slide right here. That dark spot, that's a amyloid plaque, and these little collection right here is what a neurofibrillary tangle looks like. These are the classic sort of pathologic findings in the brain of people with Alzheimer's disease. This is what the brain looks like if if you were to compare the brain of someone who'd had Alzheimer's disease for years, you would see that it's somewhat shrunken as compared to a normal brain due to a loss of nerve cells. It's kind of a problem because we get brain atrophy as we age. So I see patients in my office who are in their 70s or 80s who have problems with memory and thinking, and some of them have some atrophy on a CT scan or an MRI scan. But I can't look at that MRI or CT and say, well, that atrophy is due to Alzheimer's, or is it just due to a normal aging change? So it's very hard to diagnose Alzheimer's disease from a CT scan or an MRI scan. We still do them to make sure that there aren't other conditions which could be affecting brain function. So we want to, rule out certain things. But the brain definitely changes. And that picture on the right of the Alzheimer's brain, that would be a pretty advanced case of Alzheimer's disease to see that much loss of brain cells. A question comes up. This is a serious problem. It's a problem that's increasing. How would we screen people for Alzheimer's disease? And we have these different groups: the U.S. Preventive Services Task Force, the American Academy of Neurology, the Canadian Task Force on Preventive Healthcare. They've all looked at studies of screening for dementia in asymptomatic individuals, and have not found any evidence to support screening in asymptomatic adults. So there is not a recommended screening test. Now, I have to say that lately on these screenings for the Medicare annual wellness exam, if any of you are reaching Medicare age, your doctor is going to go through a fairly lengthy review of various potential health concerns. And in some of these annual wellness exams, they will ask a question: do you have problems with memory? Again, it may be useful, when many people do recognize when they're having problems and come to me with concerns that turn out to be Alzheimer's disease. But I would say the majority of people who have early dementia or mild dementia are unaware of the problem. They don't recognize it as the problem, whereas people around them might. And then, as far as the screening and evaluation goes, if you know of someone who's complaining of problems with memory, or if you observe problems with memory or cognition, behavioral change, or, I would tell a physician, if a physician becomes concerned that someone's not able to follow through on recommendations or appears to be having problems with memory or thinking, in every case, it should be fully investigated. So it's not that when we say we're not endorsing screening, we're not saying we're trying to ignore the problem. It needs to be investigated, and it may be that there are better procedures in order to screen for and identify persons who might have dementia. I see any number of patients here who get referred for evaluation, and when I look in their electronic medical record, there's no mention of dementia. It's not always picked up. It's not always identified in primary care. So one idea would just to have physicians be more conscious and be sure to be able to document it when they see it. A little bit about genetic testing. And this is becoming an important topic because of these direct to consumer. Any of you can order a test for Alzheimer's disease. It can be done. So most cases of Alzheimer's disease are sporadic, and there are multiple factors that lead to Alzheimer's disease. Not everybody, in fact, less than half the people with Alzheimer's disease have an identifiable genetic risk for it. So genes are helpful up to a point, but they're not diagnostic. The one that you can order is this ApoE4 gene. The ApoE gene has three forms. If you have ApoE2, it's actually protective. There's a lower rate of Alzheimer's disease. The E3 is the most common, 78%, and is not associated with Alzheimer's disease. But if you have that ApoE4 gene, it is associated with an increased risk of Alzheimer's disease. If you have one copy of it, your risk of Alzheimer's is 2 to 3 times what the average population would be. If you have 2 copies, it's 8 to 12 times more likely that you will develop Alzheimer's disease. And I'd mentioned you can get these tests direct to consumer. They're not terribly expensive. I guess one of the questions is what to do with the information. I don't order these tests on patients. There may be a rare situation where I might order this test where there's some confusion about diagnosis. One of the problems is that when you diagnose Alzheimer's disease or really some of the other conditions, there isn't a specific treatment available right now that's known to reverse the disease or keep it from getting worse. So that figures into the thinking about the different kinds of testing that might or might not be done. Genetic testing is sometimes used to identify persons who might be at increased risk or who might be in a preclinical stage. You'd like to, if you're going to have a treatment to try to prevent Alzheimer's disease, you'd like to start that treatment before people have significant symptoms. So you could use genetic testing as a way to identify people at risk. And there are a number of gene studies that are going on around the country where family members can participate in studies related to Alzheimer's disease on the basis of genetic risk. These are some biomarkers. When I say biomarkers, these are tests that can be done that might be used to diagnose someone with Alzheimer's disease or even to screen for Alzheimer's disease in a preclinical time before there are symptoms. So this amyloid PET scan has been developed in the last number of years, and what it is it's you inject a material and it goes in and it binds to amyloid in the brain and it lights up. When you do an MRI, you can see the amyloid, and I'll show you the picture in just a minute. And there's a similar type of a scanning test using for tau protein to look for abnormal tau protein deposits in the brain. So both of these tests are out there. They're mainly used for research purposes. They're not widely available to go in and get a test to see if someone has Alzheimer's disease or not. A second type biomarker are these spinal fluid proteins, A-beta 42, A-beta 40. Those are amyloid protein products, and you can measure those in the spinal fluid, and then these other tau protein products can also be measured in the spinal fluid, and they can help confirm a diagnosis of Alzheimer's disease if there's uncertainty about it. And then finally, just within the last year, there's been a blood test developed for p-tau217. And reading over the study, it was the blood test study was developed in subpopulations who had high risk for Alzheimer's disease, and whether or not this test will be useful widely to screen for, to identify people who are likely to develop Alzheimer's disease is still not known. But that's has come out in the last year, and so there's going to be more research on this. And this blood p-tau217 correlates very highly with the amyloid PET scan and these other tests that are more complicated and more expensive to do. And the day may come when you can get a direct-to-consumer blood test for Alzheimer's disease. So we're not there yet, but it may be coming. This is just a kind of a graphic of what an amyloid scan looks like, and you can see that that the amyloid lights up. It's just a marker that can be injected and will go to where amyloid is in the brain, and then the normal brain doesn't light up in the same way. So these amyloid scans can be used to differentiate Alzheimer's disease from other conditions. So just sort of in summary, these biomarkers can discriminate between Alzheimer's and other causes of dementia. They have limited use due to the high cost and the fact that they're fairly invasive procedures. There's no proven benefit for outcomes because there's not any effective therapy. So when the PET scan came out, they said, well, does knowing the results of the PET scan change the treatment for the doctors? In some cases, it does change the treatment. So if I had someone who I wasn't sure had Alzheimer's disease, but they had a positive amyloid scan, I might start them on Aricept sooner than I would have had I not done a PET scan. The problem is we don't know how that will affect outcome. We don't know whether that really will benefit the patient in a major way or not. There aren't studies, the studies that have been done with Aricept on people who have mild cognitive impairment haven't shown a benefit. So there's a long way to go to know how to use these biomarkers in an effective way beyond research. I think there's lots of use for them in research. So kind of finally getting down to the topic of today's discussion about preventing Alzheimer's and thinking about what we can do to prevent Alzheimer's disease. I get lots of questions about Prevagen and other supplements and brain health and how do they help us prevent Alzheimer's disease, or do they help people do better who do have Alzheimer's disease? One of the resources I look at, I look at mainly at medical journals, and in the January 2018 issue of the Annals of Internal Medicine, they published several of these meta-analyses that looked at all the research that had been done on these different interventions for Alzheimer's disease. And this was done, with a big group where they looked at all the databases. They reviewed thousands and thousands of studies to try to identify evidence that would help us give advice one way or the other about preventing Alzheimer's disease. So they reviewed, and all of these studies looked more or less at the same time period. They looked at all the published studies between 2009 and July of 2017. And I can promise you there were thousands of studies that looked at supplements that got published, but you have to have criteria to decide whether a study gives good information or not. And they found 38 trials with low to medium risk of bias comparing over-the-counter supplements and vitamins to a placebo. And there was some high attrition, short follow-up. There are a lot of limitations with many of the studies that were done. Adverse events were rarely reported when they looked at trials of supplements. And the conclusion was that there's just not enough evidence to recommend any of the over-the-counter supplements or vitamins to protect the brain or to improve brain function in people with normal cognition or mild cognitive impairment. So then another review looked at pharmacologic interventions, looking at drugs. So over the years, the question has come up, does estrogen protect your memory as you get older? Do NSAIDs, they're anti-inflammatory. If you took Advil or Naproxen, could that prevent you from having Alzheimer's disease? So they looked at, again, they found 51 trials over this time period of about 7 or 8 years that were reasonably done, placebo-controlled trials looking at cholinesterase inhibitors. That would be a drug like Aricept or galantamine, one of those kinds of drugs. They looked at blood pressure medications. They looked at anti-inflammatories and lipid-lowering agents. Again, these studies were all limited by attrition. And not all of these studies use the same cognitive measures or look for the same outcomes. So in some cases, it's kind of hard to compare. And then there's always what's called publication bias or reporting bias. So many studies that are negative never get published. Despite that, the evidence that they could see from the 51 trials that they looked at, they don't support the use of any of the studied pharmacologic treatments for cognitive protection in persons with normal cognition or MCI. So none of these pharmacologic drugs seem to be helpful. What about cognitive training? This, again, doing these computer training, doing Sudoku. I do Sudoku every chance I get. I try to do crossword puzzles. I enjoy doing them, but the results from research studies, don't give us a strong feeling. They were able to find 11 studies that looked at brain training, and they identified studies with a low risk of bias. These studies lasted at least 6 months, and they compared cognitive training with either usual care or a wait list or providing information. So just providing information or a wait list would be sort of like the placebo arm of a cognitive training trial. Again, these studies have some limitations in terms of how outcomes were measured. Publication bias may have been a problem in these studies as well. And their conclusion was that in older adults with normal cognition, training does improve performance in the domain that gets trained. The evidence that it delays cognitive decline or dementia is not sufficient. So I can't recommend brain training as a way to prevent you from getting Alzheimer's disease, at least based on the research studies that have been done to date. I think it is helpful to think about, health concerns that could contribute to deterioration in brain function and see what might be preventable. I've spent a lot of time mentioning the fact that vascular disease is a risk factor. And so some of the prevention of brain disease or Alzheimer's disease centers around managing problems that affect vascular function, things like heart disease. So there have been reports from time to time that certain types of medications might influence the development of dementia. Drugs, sleeping pills, drugs like Ambien have been associated with dementia. And various other medications. Whether there's a direct cause-effect relationship is not clear to me from some of these studies, but we certainly want to minimize drugs that might be more toxic to older brains than they would be to younger brains. So it includes many over-the-counter drugs like Benadryl, drugs that are often used for dizziness, meclizine, or drugs for itching. Any of these antihistamines or anticholinergic drugs have the potential to cause some confusion or changes in cognition in people who are susceptible. Cigarette smoking is a big risk factor for vascular disease of any type, and is certainly just not recommended by doctors anywhere anymore. Alcohol use comes up fairly frequently. For a while, we were promoting red wine as a way to maintain brain function. The World Health Organization last year came out and says, there aren't really any good studies that promote that can support the use of any amount of alcohol to prevent dementia or Alzheimer's disease. So I'm not sure that you certainly want to be cautious about alcohol use as you get older. Certainly, if you have early dementia, alcohol use can affect memory and thinking in certain ways. We'll get into that a little bit more. Diet, again, as it relates to vascular risk factors. Sleep has been studied, and I've read reports that link poor sleep to the development of cognitive impairment. Physical exercise and physical activity probably does have some benefits for maintaining brain function. And the last thing, social activity, again, is in some studies shows a benefit. People who have a cause that they're related to, or people who have frequent social interactions, it stimulates brain function in ways that may be beneficial and may have effects as well on quality of life. Again, I've touched on these vascular risk factors. Most of this, for most of you, is very straightforward stuff that you all know. I don't really need to emphasize it, but controlling blood pressure and cholesterol, vascular risk factors, comes up over and over again because it is an important contributor to brain disease, all of these vascular risk factors. Diabetes, again, is just on the list. All of this is straightforward and things that you all probably know. Brain injury is something to think about. I'm a bicycle rider. I like to get on my bike and ride up into the mountains, and I always wear a helmet. And I'll tell you, from time to time, people I've known riding bikes hit the ground or get hit by a car or something like that. And I know I have a close friend I used to ride with who's had a brain injury, and it certainly is a risk for effects on cognition. So I think just regular safety measures. Also, if you have a difficulty with walking, or if you know someone who has a gait impairment, that also puts them at risk of a head injury. So paying attention to gait problems, walking problems, balance problems, it has a potential to prevent more serious problems with brain function and cognition down the line. So brain injury is not a rare cause of cognitive impairment in older patients or in younger patients. Smoking, I won't belabor it anymore. Don't smoke. Alcohol, again, I had touched on this earlier. Alcohol can interfere with sleep. It can affect memory. It can alcohol is a risk factor for atrial fibrillation, which is then a risk for stroke. So there are different ways that alcohol can have adverse effects on the brain as we age. So can we prevent brain disease? I'd say the answer is yes. These aggressive, I think there's already been some evidence from looking at longitudinal data on incidence of dementia that the most likely way to account for that is this early recognition of risk factors and risk factor modification throughout the lifespan. The changes that are going to lead to dementia in your brain in late life probably begin in the 30s or 40s. There are vascular changes that they can now see on some of these high resolution scans in people with hypertension and diabetes at a very early age that may be changes that lead to the findings that we see in persons who end up with dementia later on. These other conditions, again, like atrial fibrillation and sleep apnea, making sure that those are identified and treated. Sleep apnea can lead to low oxygen levels. Low oxygen levels can then lead to neural cell loss, loss of brain cells, and impaired cognition. Promoting brain health, yes, exercise probably does help. Again, there's some data from population studies that suggest that people who are regular exercises throughout their lifespan develop Alzheimer's disease about 10 years later than people who are sedentary. So those aren't, it's not the same thing as a controls trial, but these population studies are pretty strong. And there are a few exercise studies that show some benefits in terms of brain health and memory. Again, exercise also reduces risk from some of the cardiovascular conditions that can lead to brain injury and dementia. Social engagement. Diet is a tricky one. You know, we think about diet in relation to prevention of cardiovascular disease. There are some population studies that would suggest that in populations that eat a largely Mediterranean diet, that they may develop Alzheimer's disease later in time than people that eat a Western diet or a diet that's not as healthy. But I would promote the same diet for your brain that is also good for your heart and for diabetes and for your blood pressure. And then brain training, we saw that there's some studies that indicate some improvement in certain functions in healthy people. Whether it actually prevents Alzheimer's disease or not is not clear. Again, the exercise I had talked about. I always shoot for this 150 minutes of exercise a week. I tell people to exercise at least 30 minutes a day. And the kind of exercise you do depends on sort of what your baseline health status is. People with bad knees and hips and backs probably shouldn't be running, but there are other exercises that are just as good. That 30-minute walk every day is actually a real good baseline exercise. And there are many, many studies that show benefits for conditions like diabetes, blood pressure, and heart disease from regular exercise. So I think that indirect effect on improving brain function down the line is a given. So I promote exercise. I'm not a lifelong exerciser. I came to it fairly late, but I'm sold on it now. Social engagement I talked about earlier. This comes up over and again when we look at studies of dementia and people who develop dementia. Again, a study like this is hard to do because I think one of the reasons that people engage less socially or withdraw from social activities is because they're developing a memory problem or developing dementia. And that's why I would encourage us, as a culture, as a society, to find ways to promote this idea of a dementia-capable community, a dementia-capable society. We need to live in a society where having brain impairment and memory loss is understood, and that we care for people who have those problems, that we find ways to include them in activity. I'll go ahead and just kind of finish off up. I'm going to put in I want to talk just briefly. This is a study that just came out less than a year ago. There are these monoclonal antibody studies. There have been a number of them looking at trying to stop amyloid production. This was donanemab as a antibody that targets beta amyloid in the brain, and it has been shown to reduce plaque levels. This was a report of a randomized controlled trial that looked at 257 patients. 131 in the treatment group, 126 in the placebo group, who had very early Alzheimer's disease. And they had positive PET scans. They had positive PET scans that showed that there was either amyloid or tau protein. And giving this monoclonal antibody did show at 76 weeks that there was some improvement on some of the scores in cognition and some of the daily activity scores. Now, there was a lot of dropout from the treatment group. And again, there were, I think, they looked at what, well over 1,000 people referred to the study, but could only accept a certain number. So it looked at a very defined group to do this study, but it did demonstrate that there are potential ways to limit this disease at an early stage. And so I think this will lead to further studies that go longer in looking at the efficacy and safety. But there were quite a few adverse effects in the treatment group. So I'm not sure that these monoclonal antibodies are quite the silver bullet we've been looking for, but more studies are ongoing. And I'm very, very hopeful. There are hundreds of studies going on right now looking at Alzheimer's disease around the country. So I'm very hopeful that we'll find ways to help this problem. This is just a shameless plug. If you're in the Greenville area and you have a loved one who's concerned about you're concerned might have Alzheimer's disease, or if you're worried about memory loss and you feel like you need an evaluation, you can have your physician refer to the memory health program. We're part of Prisma Health, but we will see anyone. I work with a very special group of people who specialize in this problem of dementia, and we work very, very closely with patients and with families to try to help manage this condition. And we work closely with their primary care physicians as well. So none of us are neurologists. There's several of us who have worked in geriatric medicine for years. We have nurse practitioners who are specialized in caring for people who have dementia and working with family members. We have a social worker. Our nurses that work here know how to test people and do these brain function tests. They're excellent at that. So we have this special program, and we're always happy to try to be helpful if you have any of these concerns. So that's my shameless plug from Prisma Health for today. But I'll go ahead and just be available now. Just we've had these courses where we offer training for caregivers. Many of these are on hold right now because of COVID, but we're looking forward to trying to reinstitute some of these courses for caregivers that we've had in the past. There's a phone number that you can call to get information about our program. But like I say, we do request a referral. We want to make sure that our evaluation goes back to your primary care physician, and that we work together to help manage a problem like this that has to be managed carefully and over time. So. And that's it. What do you think? Questions?
Well, thank you so much, Dr. Davis. We do have several questions rolling in, so I'll just kick us off with those, and we'll get to as many of them as we can in the next few minutes. Okay. So this participant says, many people and doctors have told me that diet, for example, too much aluminum, metals, not enough healthy fats, has to do with Alzheimer's. And then others say it's genetics and DNA. Now I'm hearing it's neither. What is your take on this? Well, I say it's both. It's not neither. So genes, there's definitely a genetic risk. And there are probably other genes besides the ApoE4 that increase risk. But when we say that, genes just increase the risk. They're not sufficient. Having that gene is not sufficient to have the disease, but it means you're at increased risk. And yes, aluminum and other heavy metals in high concentrations have been associated with neurologic disease. There's no evidence that using aluminum cooking pots leads to Alzheimer's or dementia. And diet, any recommendations around diet are tricky because it's very hard to do long-term diet studies. Alzheimer's disease
is developing for 6 or 7 years before a person even has that first symptom. And really, when we think about preventing vascular problems, we're thinking about sort of a lifelong diet. So it may be years and years to know what the benefits are. I think good advice for now is that either a plant-based diet or a Mediterranean type diet is so good for you in other ways, it's likely to be able to help prevent Alzheimer's disease, certainly in some people. But they're right. It's not either or. It's probably a number of things that contribute to the development of dementia and to Alzheimer's disease.
Okay, another question. What is the biggest thing someone that has one variant of the ApoE4 gene can do to prevent dementia?
Well, again, the person who's already at increased risk, I would certainly, have them pay attention to all those vascular risk factors. Having the ApoE4, if you've got one copy of it, it just means your risk is greater than the average population. It doesn't mean you will get it. One of the things that comes up about doing these genetic tests is some people say, well, wouldn't I plan my life differently? Wouldn't I be, making different plans if I knew my risk was greater? My response to that is all of us are at risk of developing, changes in brain function as we age. Everyone has to have a game plan when they're in their 70s and 80s. It's not, it's wise for any of us to be thinking about the what ifs, in terms of things that could happen to us. So I would tell that person, yeah, I'm concerned that, that you might be a carrier. They may want to look into research studies that might be looking at people with genetic risk to see if there are things like that where they could help contribute to what we know about genetic risk. But really the lifestyle changes that we talked about earlier for prevention hold true whether you have that ApoE4 gene or not. I don't know of anything special for someone who might be a carrier that would be different.
Great, thank you. So kind of going off of that, and I know you mentioned this a bit in your presentation, but there are several questions about if there's hereditary connections to dementia.
Well, there is. So even without doing gene testing, if you have a first degree relative who has Alzheimer's disease, a parent or a brother or sister, you have a higher risk than average of getting it yourself. So yes, there's definitely a genetic risk from that standpoint. If you have multiple family members who've had Alzheimer's disease, your risk of getting it is higher. It's also true if you have people who have vascular risk factors, people, a strong family history of diabetes or hypertension. Those are both conditions that affect the circulation and affect the circulation to the brain, and your risk of developing brain disease later in life from vascular disease is somewhat higher. So all of those genetic factors are at play. So the answer to the question is yes. To quantitate it exactly how much is difficult. There's some data on the ApoE4 genes, but less data just on having a relative. But yes, the risk is increased. And it's not substantially, it's just there. People come in all the time, well, my mother had it, so I'm worried about having it. And I can say, well, your risk is a little higher, but it doesn't mean you're going to get it. Here's what you need to do. You need to get out and exercise 30 minutes every day for the rest of your life. And that will, that should help.
We'll have a lot of things.
Right.
All right, another question is there an average age one might expect if you're considered relatively healthy to experience normal memory loss, minor word difficulties, etc.?
Great question. So when they do these serial neuropsychological assessments to evaluate brain function change, we know that brain changes begin at about age 55. There's a loss of myelin in the brain. The speed of nerve transmission is related to the amount of myelin in the brain. So that atrophy, early atrophy and changes in brain function probably begin, in the early to mid 50s and progress throughout the rest of the lifespan. I think it's important to note that these changes that result in some slowing of mental processing probably have a survival benefit. If we say our brains are slowing down in certain ways, it means we're less impulsive. We're less likely to jump to conclusions. The different way of thinking that happens in 50 and 60-year-olds, it's not a, it's a reason that people that get to be senators and CEOs and even president, the older brain may be better suited for tasks like that than a 20-year-old brain, or certainly than a 20-year-old brain, or even a 30 or 40-year-old brain. So these age-related changes aren't all negative. I don't want us to think of them that way. I try not to. So.
Great, thank you. All right, I know we're running up on time, so I'm going to ask one more question. Do natural substances such as ginseng help with prevention or lessening the effects of dementia? Are there any other natural substances that you would recommend?
Right. I'd be happy to refer you to this series of studies. So the way, I look at it is from a, kind of a medical perspective. There was one of the slides that I had was a review that reviewed all of the scientific reports that they could find that looked at substances like ginseng, vitamin E, other preparations, and looked at the studies that were done and tried to identify studies that were designed in a way that could tell the difference. So you have to have a placebo-controlled trial to know what the benefits are and what the harms are from these substances. And the first thing you see is that there are very few trials that are conducted that measure the outcomes of interest well enough and that are done in a randomized way to give us information on this. So as a result, since I don't have that information, I can't base that information on any knowledge base, and I usually don't recommend these substances. So, that's kind of my take on it. I hear about it a lot. I review it with patients. There's a theoretical reason to think that certain substances like vitamin E and a couple of these other natural substances serve as antioxidants. They may interfere with inflammation in a certain way. There's a theory that they are what are called free radical scavengers, and that they interact with the inflammatory process, and that in that way they may have a preventive effect in terms of decline in brain function. That's a theoretical reason why you have all these substances are out there. That's what is there's just no proof that that's actually what happens, and that actually works that way. So there's another big group that look at these multiple risk factors like diet and diabetes and all of these, and try to think of all the different ways you could look at hormone levels, look at all of these levels, and try to optimize all of these things as a way to prevent Alzheimer's disease. And again, there are any number of people out talking about this, but practically there's just not a way that doctors like me or doctors in general or scientists can give you an answer as to whether that works or not.
Great. Well, thank you so much. What a wonderful presentation. And thank you everyone for joining and for your questions. So many fantastic questions today. I know you all are going home with lots of great takeaways, as am I. So thanks to everyone for joining. If you're interested in any more of our Spring into Health events as a partnership with Prisma Health, you can see those at uofscalumni.org/events. And once again, thank you to Prisma Health for making today's event possible. And thank you so much, Dr. Davis, for your time.
Thank you. It was fun. I enjoyed actually. This was a new talk for me, so it really got me looking things up. I really appreciate the opportunity, and would appreciate any feedback that you can get to me from people that participated that could be helpful for me to either address other issues that might be important or to do things in a better way. I'd love to hear back from you. I appreciate that.
Absolutely. Yes, you all should be getting a survey email coming your way soon, so be sure to share that.
Thank you. Thank you.
Yeah. All right, everyone. Have a great afternoon.